First aid. First aid is the emergency treatment given to the ill or injured before professional medical services can be obtained. It is given to prevent death or further injury, to counteract shock, and to relieve pain. Certain conditions, such as severe bleeding or asphyxiation, require immediate treatment if the patient is to survive. All crew members should be prepared to administer first aid. We should have sufficient knowledge of first aid to be able to apply true emergency measures and decide when treatment can be safely delayed until more skilled personnel arrive. Priorities in case of emergency. On finding a casualty, we should look to our own safety, not become the next casualty. If necessary, remove the casualty from danger, or remove danger from the casualty. If there is only one casualty, give immediate treatment to the casualty who is not breathing and/or whose heart has stopped, is bleeding severely or unconscious. Others can be treated later. Send for help. If there is more than one unconscious or bleeding casualty, we should first send for help. Treat the most serious injury first in the order of not breathing and/or heart stopped, unconsciousness, serious bleeding. If the casualty is in an enclosed space, do not enter the enclosed space unless you are a trained member of a rescue team acting under instructions. Send for help and inform the master. It must be assumed that the atmosphere in the space is hostile. The rescue team must not enter unless wearing breathing apparatus, which must also be fitted to the casualty as soon as possible. The casualty must be removed quickly to the nearest safe adjacent area outside the enclosed space, unless his injuries and the likely time of evacuation make some treatment essential before he can be moved. General principles of first aid aboard ship. Make a rapid examination of the patient to assess responsiveness and the extent of the injury. Check breathing, heart, and look for serious bleeding. If breathing has stopped, give artificial respiration. If the heart has stopped, give heart compression and artificial respiration. Arrest serious bleeding. Handle the patient as little and as gently as possible to prevent further injuries and prevent further shock. See that the patient is put in the most comfortable position possible and loosen tight clothing so that he can breathe easily. Do not remove more clothing than is necessary, and when you do, remove it gently. With an injured limb, get the sound limb out of the clothing first, and then peel the clothes off of the injured limb, which should be supported by another person during the process. If cutting clothes is indicated to expose the injured part, do so. In removing a boot or shoe, remove the lace. If necessary, cut the upper down towards the toe cap. Keep onlookers away. Always remember that shock can be a great danger to life, and one of the main objects of first aid is to prevent this. You may have to improvise splints, bandages, etc. Do not give alcohol in any form. Do not move the patient until he is fit to be moved. Bleeding should be arrested, fractures immobilized, and shock treated. See that the necessary personnel and equipment for smooth and efficient transport are available. Never consider anyone to be dead until you and others agree that breathing has stopped, no pulse is felt, and no sounds are heard when the examiner's ear is put to the chest. The eyes are glazed and pupils are dilated. There is a progressive cooling of the body. General assessment of the situation. Once it has been established that there is no immediate threat to life, there will be time to take stock of the situation. Reassurance and quick and effective attention to injuries and compassionate treatment of the injured person will alleviate his condition. Remember, a calm and systematic approach should be adopted. Give nothing by mouth. Protect the casualty from heat or cold, remembering that in the tropics, open steel decks can be very hot. Never underestimate and do not treat as minor injuries unconsciousness, suspected internal bleeding, stab or puncture wounds, wounds near joints, possible fractures, eye injuries. Congratulations! You have successfully completed Part 1. Please continue with Part 2. Part 2. Body Structure and Functions. Please click the Next button to proceed. After completing this part of the training, you will have the basic knowledge of anatomy when examining a patient or obtaining and acting on radiomedical advice. The skeleton system. The skeleton is the structure that gives us our shape, provides protection for our internal organs, and offers a supportive framework for the attachment of muscles, therefore facilitating movement. Our bones also act as a site for the production of blood cells and a store of minerals, particularly calcium. The skeleton has 5 main functions: support, protection, movement, blood cell production, and mineral store. Bone is made of collagen fibers filled with minerals, mainly calcium salts. There are 5 types of bone in the skeleton that are classified according to their shape. Long bones. Longer than they are wide include the femur, the longest bone in the body, as well as relatively small bones in the fingers. Long bones function to support the weight of the body and facilitate movement. Short bones are about as long as they are wide. Located in the wrist and ankle joints, short bones provide stability and some movement. Flat bones. In the skull, occipital, parietal, frontal, nasal, lacrimal, and vomer, the thoracic cage, sternum and ribs, and the pelvis, ilium, ischium, and pubis. The function of flat bones is to protect internal organs, such as the brain, heart, and pelvic organs. Irregular bones vary in shape and structure, and therefore do not fit into any other category. Sesamoid bones are bones embedded in tendons. These small, round bones are commonly found in the tendons of the hands, knees, and feet. Sesamoid bones function to protect tendons from stress and wear. Please review the bone structure of a body.
तो मैं नहीं खेल सकता ना, बट मैं ये बोल रहा हूँ। आज मैंने खाना खाया, आज काम चल रहा है, आज
Please review the bone structure of a body. The muscular system. 1. Voluntary muscles. 2. Involuntary muscles. 1. Voluntary muscles. These form the bulk of the fleshy parts of the body. They are fixed to the bones by blending with the sheaths of fibrous tissue surrounding the bones. Some are attached directly to a wide area of bone surface, but others taper to form a strong cord, tendon, or leader, which is attached at a specific place on a bone. Muscles, and especially those of the limbs, are arranged in 2 opposing groups. Contraction of one group in response to an impulse through the nerve supply must be accompanied by simultaneous relaxation of the opposing group, or movement will not take place. These movements are under conscious control. 1. Voluntary muscles. These form the bulk of the fleshy parts of the body. They are fixed to the bones by blending with the sheaths of fibrous tissue surrounding the bones. Some are attached directly to a wide area of bone surface, but others taper to form a strong cord, tendon, or leader, which is attached at a specific place on a bone. Muscles, and especially those of the limbs, are arranged in two opposing groups. Contraction of one group in response to an impulse through the nerve supply must be accompanied by simultaneous relaxation of the opposing group, or movement will not take place. These movements are under conscious control. 2. Involuntary muscles. These are found in the stomach and intestines, in the heart and blood vessels, and also in other internal organs of the body. They continue to work throughout life as part of natural body function outside the control of personal will. Joint. A place on the body where two or more bones meet. Joints are links between the bones of the skeleton. They act to allow movement, but also work to stabilize areas of the body. Tendon. A very strong connective tissue that attaches skeletal muscle to bone. Tendons may also attach muscles to structures such as the eyeball. A tendon serves to move the bone or structure. Please review the muscle structure of a body. The major organs. 1. Brain. 2. Heart. 3. Lungs. Brain. The brain is one of the largest and most complex organs in the human body. It is made up of nerves that communicate in trillions of connections called synapses. The brain is made up of many specialized areas that work together. The brain is also divided into several lobes. The frontal lobes are responsible for problem solving and judgment and motor function. The parietal lobes manage sensation, handwriting, and body position. The temporal lobes are involved with memory and hearing. The occipital lobes contain the brain's visual processing system. Heart. The heart is a muscular organ about the size of a fist, located just behind and slightly left of the breastbone. The heart pumps blood through the network of arteries and veins called the cardiovascular system. The heart has 4 chambers. The right atrium receives blood from the veins and pumps it to the right ventricle. The right ventricle receives blood from the right atrium and pumps it to the lungs, where it is loaded with oxygen. The left atrium receives oxygenated blood from the lungs and pumps it to the left ventricle. The left ventricle, the strongest chamber, pumps oxygen-rich blood to the rest of the body. The left ventricle's vigorous contractions create our blood pressure. Lungs. The lungs are the primary organs of the respiratory system in humans and many other animals, including a few fish and some snails. In mammals and other vertebrates, 2 lungs are located near the backbone on either side of the heart. Their function in the respiratory system is to extract oxygen from the atmosphere and transfer it into the bloodstream, and to release carbon dioxide from the bloodstream into the atmosphere in a process of gas exchange. The circulatory system. 1. Blood. The body contains about 5 liters of blood, which consists basically of 4 constituents: plasma, red cells, white cells, and platelet cells. The plasma is the liquid component of the blood which circulates to all the tissue cells throughout the body. It distributes food, water, salts, and heat, and collects waste products which are subsequently excreted. The red cells predominate and give the blood its color. This color is derived from a complex iron compound, hemoglobin, which is the main oxygen carrier. The white cells give protection against infection by attacking and killing bacteria, and also by producing substances which are necessary for building up resistance to further infections. The main purpose of platelets is to assist in the blood clotting mechanism. 2. Heart. The heart is a thick-walled muscular pump. It is divided in the midline into two sides which do not communicate. Each side has an upper and lower chamber which communicate through a main heart valve. The separate chambers are each served by a major blood vessel that either brings blood to the chamber or carries it away. The right side receives venous blood, which, having been circulated around the body, has given up its oxygen and collected carbon dioxide. This blood is pumped through the lungs where it is replenished with oxygen and discards the carbon dioxide. As purified blood, it returns to the left side to be pumped through the arteries to all parts of the body. 3. Blood vessels. The blood vessels form a closed system of tubes. The arteries, which have to take the full force of the pumping pressure, have thick walls containing muscle fibers and elastic tissue. The arteries penetrate to all parts of the body, dividing and subdividing until they narrow to form very thin-walled vessels. The capillary system is vital to the life of all tissues. The thin capillary vessel wall allows nutrients, oxygen, heat, and beneficial chemical substance to enter the cells, and, most important, waste products to be passed out into the blood. Congratulations! You have successfully completed Part 2. Please continue with Part 3. Part 3. Positioning of casualty. Please click the Next button to proceed. Once you've treated the injury or illness, you are not quite out of the woods until further help arrives. In that time, correct positioning of the casualty can aid recovery in the same way that poor positioning can very easily aggravate the injury or exacerbate the condition. Recovery position. If a person is unconscious but is breathing and has no other life-threatening conditions, they should be placed in the recovery position. Putting someone in the recovery position will keep their airway clear and open. It also ensures that any vomit or fluid won't cause them to choke. With the person lying on their back, kneel on the floor at their side. Extend the arm nearest you at a right angle to their body, with their palm facing up. Take their other arm and fold it so that the back of their hand rests on the cheek closest to you, and hold it in place. Use your free hand to bend the person's knee farthest from you to a right angle. Carefully roll the person onto their side by pulling on the bent knee. Their bent arm should be supporting the head, and their extended arm will stop you from rolling them too far. Make sure their bent leg is at a right angle. Open their airway by gently tilting their head back and lifting their chin, and check that nothing is blocking their airway. Stay with the person and monitor their condition until resuscitation position. If a person is unconscious and not breathing, they should be placed in the resuscitation position in order to carry out CPR. Congratulations! You have successfully completed Part 3. Please click the Next button to proceed. Consciousness is when a person suddenly becomes unable to respond to stimuli and appears to be asleep. A person may be unconscious for a few seconds, as symptoms that may indicate that unconsciousness is about to occur include sudden inability to respond, slurred speech, a rapid heartbeat, confusion, dizziness or lightheadedness. Careful nursing of unconscious people is a demanding, difficult, and very important task. The survival and eventual condition of anyone who is unconscious depends greatly on your care, skill, and attention. As soon as the patient has been put to bed in the unconscious position, assess the circumstances leading to the incident of unconsciousness. Using the information you have collected and the results of your examination, try to identify the cause of the unconsciousness. The following may assist in distinguishing between the main causes. Fainting. A simple faint will rarely cause difficulty. The patient has usually recovered consciousness within several minutes. and he will feel back to normal shortly without any after effects. Brain concussion. This is usually caused by a direct blow on the head, but sometimes may be caused by a fall from a height even when there has been no direct injury. It could vary in severity, from feeling dazed and shaky for a few minutes to, in very severe cases, unconsciousness lasting for hours or even days. Brain compression. Compression should be suspected if unconsciousness comes on gradually after a head injury, or if a casualty who has recovered consciousness after a head injury lapses again into unconsciousness. Epilepsy. The irregular jerking movements of the limbs will have stopped before the casualty has been taken to the ship's hospital. In a single fit, these jerking movements will not recur. The patient usually has a history of fits. Stroke. The presence of paralysis of a limb or limbs on one side of the body should, in the absence of a head injury, point to this cause. Alcohol abuse. The history obtained from witnesses or close associates will give an indication of the amount of alcohol consumed. Although a casualty's breath may smell of alcohol, his unconsciousness may not be caused by it. He may, for example, have sustained a head injury in a fall when drunk. Diabetic coma. There is usually a history of the casualty feeling unwell for 2 or 3 days before the onset of unconsciousness. The characteristic smell of the breath is very helpful. The 3 musts for unconscious patients. The unconscious patient must have a clear airway, must be kept in the unconscious position, must never be left alone. Keep a clear airway. Keeping a clear airway is essential and requires the patient to be kept in the unconscious position. Any blood, vomit, or other secretions from the mouth must be mopped out or removed by the use of a sucker. Unconscious patients must never be left alone in case they move, vomit, have a fit, or fall out of their bed. An airway should be inserted if a patient is breathing on his own but is doing so with great difficulty. The function of the airway is to ensure a clear passage between the lips and the back of the throat. First, remove any dentures and suck or swab out any blood or vomit which is in the mouth to get a clear airway. Then, with the head fully back, slide the airway gently into the mouth with the outer curve of the airway towards the tongue. This operation will be facilitated if the airway is wetted. If you notice any attempt by the patient to gag, retch, or vomit, it is better not to proceed with the insertion of the airway. If necessary, try again later to insert it. How to act. If you see a person who has become unconscious, take these steps. Check whether the person is breathing. If they're not breathing, have someone call for help immediately and prepare to begin CPR. If they're breathing, position the person on their back. Raise their legs at least 30 centimeters above the ground. Loosen any restrictive clothing or belts. Check their airway to make sure there's no obstruction. Check again to see if they're breathing, coughing, or moving. These are signs of positive circulation. If these signs are absent, perform CPR until emergency personnel arrive. If there's major bleeding occurring, place direct pressure on the bleeding area or apply a tourniquet above the bleeding area until expert help arrives. Congratulations! You have successfully completed Part 4. Part 5. Resuscitation. Please click the next button to proceed. Basic life support. Artificial respiration and heart compression. Basic life support is an emergency life-saving procedure that consists of recognizing and correcting failure of the respiratory or cardiovascular systems. Oxygen, which is present in the atmosphere in a concentration of about 21%, is essential for the life of all cells. The brain, the principal organ for conscious life, starts to die if deprived of oxygen for as little as 4 minutes. In the delivery of oxygen from the atmosphere to the brain cells, there are 2 necessary actions: breathing and the circulation of oxygen-enriched blood. ABC. Basic life support comprises the ABC steps. Its prompt application is indicated for airway obstruction, breathing arrest, circulatory or cardiac arrest. Emergency situations. If breathing alone is inadequate or absent, all that is necessary is either to open the airway or to apply artificial respiration. If circulation is also absent, artificial circulation must be instituted through heart compression in combination with artificial respiration. If breathing stops before the heart stops, enough oxygen will be available in the lungs to maintain life for several minutes. However, if heart arrest occurs first, delivery of oxygen to the brain ceases immediately. Brain damage is possible if the brain is deprived of oxygen for 4 to 6 minutes. Beyond 6 minutes without oxygen, brain damage is very likely. Airway. Establishing an open airway is the most important step in artificial respiration. Spontaneous breathing may occur as a result of this simple measure. Place the patient in a face-up position on a hard surface. Put one hand beneath the patient's neck and the other hand on his forehead. Lift the neck with one hand and apply pressure to the forehead with the other to tilt the head backward. This extends the neck and moves the base of the tongue away from the back of the throat. The head should be maintained in this position during the entire artificial respiration and heart compression procedure. If the airway is still obstructed, any foreign material in the mouth or throat should be removed immediately with the fingers. Once the airway has been opened, the patient may or may not start to breathe again. To assess whether breathing has returned, we must place our ear about 2 to 3 centimeters above the nose and mouth of the patient. If the rescuer can feel and hear the movement of air and can see the patient's chest and abdomen move, breathing has returned. Feeling and hearing are far more important than seeing. With airway obstruction, it is possible that there will be no air movement even though the chest and abdomen rise and fall with the patient's attempts to breathe. Also, observing chest and abdominal movement is difficult when the patient is fully clothed. Breathing. If the patient does not resume adequate, spontaneous breathing promptly after his head has been tilted backward, artificial respiration should be given by the mouth-to-mouth or mouth-to-nose method or other techniques. Regardless of the method used, preservation of an open airway is essential. Mouth-to-mouth respiration. Keep the patient's head at a maximum backward tilt with one hand under the neck. Place the heel of the other hand on the forehead with the thumb and index finger toward the nose. Pinch together the patient's nostrils with the thumb and index finger to prevent air from escaping. Continue to exert pressure on the forehead with the palm of the hand to maintain the backward tilt of the head. Take a deep breath, then form a tight seal with your mouth over and around the patient's mouth. Blow 4 quick, full breaths in first without allowing the lungs to deflate fully. Watch the patient's chest while inflating the lungs. If adequate respiration is taking place, the chest should rise and fall. Remove your mouth and allow the patient to exhale passively. If you are in the right position, the patient's exhalation will be felt on your cheek. Mouth-to-nose respiration. The mouth-to-nose technique should be used when it is impossible to open the patient's mouth, when the mouth is severely injured, or when a tight seal round the lips cannot be obtained. Keep the patient's head tilted back with one hand. Use the other hand to lift up the patient's lower jaw to seal the lips. Take a deep breath. Seal your lips round the patient's nose and blow in forcefully and smoothly until your patient's chest rises. Repeat quickly 4 times. Remove your mouth and allow the patient to exhale passively. Repeat the cycle 10 to 12 times per minute. Heart compression. In attempting to bring back to life a non-breathing person whose heart has stopped beating, heart compression should be applied along with artificial respiration. Artificial respiration will bring oxygen-containing air to the lungs of the victim. From there, oxygen is transported with circulating blood to the brain and to other organs. Effective heart compression will, for some time, artificially restore the blood circulation until the heart starts beating. Technique for heart compression. Compression of the sternum produces some artificial ventilation, but not enough for adequate oxygenation of the blood. For this reason, artificial respiration is always required whenever heart compression is used. Effective heart compression requires sufficient pressure to depress the patient's lower sternum about 4 to 5 centimeters in an adult. For chest compression to be effective, the patient must be on a firm surface. Kneel close to the side of the patient and place the heel of one hand over the lower half of the sternum. Avoid placing the hand over the tip of the breastbone, which extends down over the upper abdomen. Pressure on the xiphoid process may tear the liver and lead to severe internal bleeding. Feel the tip of the sternum and place the heel of the hand about 4 centimeters nearer the head of the patient. Your fingers must never rest on the patient's rib during compression, since this increases the possibility of rib fractures. Place the heel of the other hand on top of the first one. Rock forward so that your shoulders are almost directly above the patient's chest. Keep your arms straight and exert adequate pressure almost directly downwards to depress an adult's lower sternum 4 to 5 centimeters. Depress the sternum 60 times per minute for an adult if someone else is available to give artificial respiration. This is usually enough to maintain blood flow and slow enough to allow the heart to fill with blood. The compression should be regular, smooth, and uninterrupted. Compression and relaxation being of equal duration. Under no circumstances should compression be interrupted for more than 5 seconds. ABC with 2 rescuers. It is preferable to have 2 rescuers because artificial circulation must be combined with artificial respiration. The most effective artificial respiration and heart compression are achieved by giving 1 lung inflation quickly after each 5 heart compressions, 5 to 1 ratio. The compression rate should be 60 per minute if 2 rescuers are operating. 1 rescuer performs heart compression while the other performs at the patient's head, keeps it tilted back, and continues rescue breathing. ABC with a single rescuer. A single rescuer must perform both artificial respiration and artificial circulation using a 15 to 2 ratio. 2 very quick lung inflations should be delivered after each 15 chest compressions, without waiting for full exhalation of the patient's breath. A rate equivalent to 80 chest compressions per minute must be maintained by a single rescuer in order to achieve 50 to 60 actual compressions per minute, because of the interruptions for the lung inflations. Checking effectiveness of heart compression, pupils and pulse. Check the reaction of the pupils. If the pupils contract when exposed to light, this is a sign that the brain is receiving adequate oxygen and blood. If the pupils remain widely dilated and do not react to light, serious brain damage is likely to occur soon or has occurred already. Dilated but reactive pupils are a less serious sign. The neck pulse should be felt after the first minute of heart compression and artificial respiration, and every 5 minutes thereafter. The pulse will indicate the effectiveness of the heart compression or the return of a spontaneous effective heartbeat. Other indicators of this effectiveness are expansion of the chest each time the operator blows air into the lungs, a pulse that can be felt each time the chest is compressed, return of color to the skin, a spontaneous gasp for breath, return to a spontaneous heartbeat, terminating heart compression. Deep unconsciousness, the absence of spontaneous respiration, and fixed, dilated pupils for 15 to 30 minutes indicate cerebral death of the victim, and further efforts to restore circulation and breathing are usually futile. In the absence of a physician, artificial respiration and heart compression should be continued until the heart of the victim starts beating again and breathing is restored. The victim is transferred to the care of a doctor or other health personnel responsible for emergency care. The rescuer is unable to continue because of fatigue. Congratulations! You have successfully completed Part 5. Part 6. Bleeding. In this part of the training, we will explain how to control bleeding. Please click the next button to proceed. Bleeding. The human body contains approximately 5 liters of blood. A healthy adult can lose up to half a liter of blood without harmful effects, but the loss of more than this can be threatening to life. Hemorrhage. Hemorrhage from major blood vessels of the arms, neck, and thighs may occur so rapidly and extensively that death occurs in a few minutes. Hemorrhage must be controlled immediately to prevent excessive loss of blood. External and internal bleeding. Bleeding may occur externally following an injury to the outside of the body, or internally from an injury in which blood escapes into tissue spaces or the body cavity. Fluid should not be given by mouth when internal injury is suspected. The signs and symptoms of excessive loss of blood are weakness or fainting, dizziness, pale, moist, and clammy skin, nausea, thirst, fast, weak, and irregular pulse, shortness of breath, dilated pupils, ringing in the ears, restlessness, apprehension. The patient may lose consciousness and stop breathing. The number of symptoms and their severity are generally related to how fast the blood is lost and in what amount. Controlling the bleeding. Bleeding may be controlled by direct pressure, elevation, and pressure at pressure points. A tourniquet should be applied only when every other method fails to control the excessive bleeding. 1. Direct pressure. The simplest and preferred method of controlling severe bleeding is to place a dressing over the wound and apply pressure directly to the bleeding site with the palm of the hand. In the absence of a sterile dressing or clean cloth, the bare hand may be used until a dressing is available. If the dressing becomes soaked with blood, another dressing should be applied over the first one with firmer hand pressure. The initial dressing should not be removed because this will disturb the clotting process. A pressure bandage can be applied over the dressing area to hold the dressing in place. The bandage should be tied over the dressing to provide additional pressure. Do not cut off the circulation. A pulse should be felt on the side of the injured part away from the heart. If the bandage has been applied properly, it should be allowed to remain in place undisturbed for at least 24 hours. If the dressings are not soaked with blood and the circulation beyond the pressure dressing is adequate, they need not be changed for several days. 2. Elevation. When there is a severely bleeding wound of an extremity or the head, direct pressure should be applied on a dressing over the wound with the affected part elevated. This elevation lowers the blood pressure in the affected part and the flow of blood is lessened. 3. Pressure at pressure points. When direct pressure and elevation cannot control severe bleeding, pressure should be applied to the artery that supplies the area. Because this technique reduces the circulation to the wounded part below the pressure point, it should be applied only when absolutely necessary, and only until the severe bleeding has lessened. There are a large number of sites where the fingers may be applied to help control bleeding. However, the brachial artery in the upper arm and the femoral artery in the groin are those where pressure can be most effective. Example of applying pressure at the brachial artery. One of the most effective pressure points for cuts on the lower arm is the brachial point in the elbow. This is where the artery is very close to the surface as it passes over the elbow joint. Tourniquet. A tourniquet should be applied to control bleeding only when all other means have failed. Unlike direct hand pressure, a tourniquet shuts off all normal blood circulation beyond the site of application. Lack of oxygen and blood may lead to the destruction of tissue, possibly requiring amputation of a limb. Releasing the tourniquet periodically will result in loss of blood and danger of shock. If the tourniquet is too tight or too narrow, it will damage the muscles, nerves, and blood vessels. If too loose, it may increase blood loss. If a tourniquet is applied to save a life, immediate radiomedical advice must be obtained. A tourniquet must be improvised from a wide band of cloth. An improvised tourniquet may be applied from folded triangular bandages, clothing, or similar material. Apply a tourniquet and how to secure it with a piece of wood. Record the time the tourniquet was applied. If you are sending the injured party to the hospital, attach a sheet of paper to his clothing or an extremity, indicating this time. Positioning of the patient. Once the bleeding has been controlled, the patient should be placed in a reclining position, encouraged to lie quietly, and treated for shock. Congratulations! You have successfully completed Part 6. Please continue with Part 7. Part 7. Management of shock. Please click the next button to proceed. Shock, following an injury, is the result of a decrease in the vital functions of the various organs of the body. These functions are depressed because of inadequate circulation of blood or an oxygen deficiency. Shock usually follows severe injuries such as extensive burns, major crushing injuries, particularly of the chest and abdomen, fractures of large bones, other extensive or extremely painful injuries. Shock follows the loss of large quantities of blood, allergic reactions, poisoning from drugs, gases, and other chemicals, alcohol intoxication, and the rupture of a stomach ulcer. It also may be associated with many severe illnesses such as infections, strokes, and heart attacks. Signs and symptoms of shock. Paleness. The skin is pale, cold, and often moist. Later, it may develop a bluish, ashen color. If the patient has dark skin, the color of the mucous membranes and nail beds should be examined. Rapid and shallow respirations. Alternatively, breathing can be irregular and deep. Thirst, nausea, and vomiting. These frequently occur in a hemorrhaging patient in shock. Weak and rapid pulse. Usually the pulse rate is over 100. Restlessness, excitement, and anxiety. These occur early, later giving way to mental dullness, and still later to unconsciousness. In this late stage, the pupils are dilated, giving the patient a vacant, glassy stare. Treatment. Eliminate the causes of shock. This includes controlling bleeding, restoring breathing, and relieving severe pain. Have the injured person lie down. The patient should be placed in a horizontal position. The patient's legs may be elevated approximately 30 centimeters to assist the flow of blood to the heart and head. The legs should not be elevated if there is injury to the head, pelvis, spine, or chest, or when there is difficulty in breathing. Keep the patient warm, but not hot. Too much heat raises the surface temperature of the body and diverts the blood supply away from vital organs to the skin. Relieve pain as quickly as possible. If pain is severe, 10 milligrams of morphine sulfate may be given by intramuscular injection. If the blood pressure is low, morphine sulfate should not be given because it may cause an additional drop in the pressure. The dosage should be repeated only after obtaining radiomedical advice. Administer fluids. Liquids should not be given by mouth if the patient is unconscious, drowsy, convulsing, or about to have surgery. Also, fluids should not be given if there is a puncture or crush wound to the abdomen or a brain injury. If none of the above conditions are present, give the patient a solution of oral rehydration salts, half a glass every 15 minutes. Alcohol or cigarettes should never be given. Congratulations! Part 8. Burns and Scalds. Please click the next button to proceed. In this part of the training, we will focus on the causes of burns and their treatments. There are 4 common causes of burn injuries on board ships: clothing on fire, heat burns and scalds, electrical burns and electrocution, chemical spills, clothing on fire. By far the best way to put out a fire on a person is to use a dry powder fire extinguisher at once. If a dry powder extinguisher is not available, then lay the person down and smother the flames by wrapping him in any available material, not made of man-made fiber, or throw buckets of water over him or use a hose. Make sure all smoldering clothing is extinguished. Heat burns and scalds. All heat burns should be cooled as quickly as possible with running cold water for at least 10 minutes, or by immersing in cold water and keeping the injured part in motion. Cooling of extensive burns, bigger than 15%, should be avoided as hypothermia will result. If it is not possible to cool the burn on the spot, the injured person should be taken to where cooling can be carried out. Try to remove clothing gently, but do not tear off any which adheres to the skin. Then cover the burned areas with a dry, non-fluffy dressing which is larger than the burns and bandage in place. Electrical burns and electrocution. In case of electric shock, make sure you do not become the next injured party when approaching any person who is in contact with electricity. If possible, switch off the current. Otherwise, insulate yourself before approaching and touching the injured party by using rubber gloves, wearing rubber boots, or standing on an insulating rubber mat. Electrical lines may be removed from the injured party with a wooden pole, a chair, an insulated cord, or other non-metal objects. Then, check the injured party immediately for breathing and heartbeat. If the injured party is not breathing, adhere artificial respiration. If the heart has stopped, apply heart compressions. Send for help. When the injured party is breathing, cool any burnt areas with cold water and apply a clean, dry, non-fluffy covering to these areas. Electrical burns may be followed by paralysis of the respiratory center, unconsciousness, and instant death. Chemical spills. Remove the contaminated clothing. Drench the injured party with water to wash the chemical from their eyes and skin. Give priority to washing the eyes, which are particularly vulnerable to chemical spills. If only one eye is affected, incline the head to the side of the affected eye to prevent the chemical from running across into the other eye. Congratulations! You have successfully completed Part 8. Please continue with Part 9. Part 9. Rescue and Transport of Casualty. Please Click the next. Transporting an injured party. The removal of a sick or injured person is a matter of importance, since his life may depend on the arrangements made, particularly if he has spinal injuries, a heart condition, or a severe fracture, with any of which he is likely to be suffering from shock. Use the utmost gentleness. Reassure your patient. Try to have a clear picture in your mind of the nature of the disability you are dealing with. Exercise common sense. Unless there is a danger from fire, explosion, or toxic substances, do not move an injured party until suspected fractures have been immobilized, severe bleeding has been stopped. Check out the best route for transport. Lift the injured party gently and carry him smoothly. Remember that every jolt causes him unnecessary pain. Transporting methods. The method of transport will depend on the situation of the injured party and the nature of the injury. If the ship is in port, it is usually best to await the arrival of an ambulance because the attendants will be experts in handling injured parties. 1. Manhandling. Ordinary manhandling may be possible, in which case 2 helpers carry an injured party, with each one using an arm to support the injured party's back and shoulders, and his spare hand to hold the injured party's thighs. If conscious, the injured party may help to support himself with his hands on the shoulders of the helpers. 2. Pick-a-back method. The simple pick-a-back method is useful only where the injured party is conscious and able to hold on by putting his arms round the carrier's neck. 3. Fore and aft carry. In a narrow space, the simple fore and aft carry may be best. One helper supports the patient under his arms and the other under his knees. 4. Three-handed seat. One advantage of the three-handed seat is that one of the helpers has a free arm and hand that can be used either to support an injured limb or as a back support for the injured party. Which of the 2 helpers has the free arm will depend on the nature of the injury. 5. Four-handed seat. The four-handed seat can be used when a heavy person has to be carried. The disadvantage of this type of seat is that the injured party must be able to cooperate and to hold on with both arms around the shoulders of the 2 men carrying him. 6. Fireman's lift. The fireman's lift, which should not be used unless the helper is as well built as the injured party, is especially useful when you have to move a man by yourself and need the use of your right hand for holding onto a ladder. Roll the patient so that he is lying face downwards. Lift him up so that when you stoop down, you can put your head under his left arm. Then, put your left arm between his legs and grasp his left hand, letting his body fall over your left shoulder. Steady yourself and then stand upright, at the same time shifting his weight so that he lies well balanced across the back of your shoulders. Hold the injured party's arm above the wrist. In this position, it is easy to carry the patient up a ladder as one hand is free to grasp the rail. 6. The drag carry method. As a last resort, the drag carry method may have to be used in narrow spaces, particularly where there is wreckage following an explosion and where it may be possible for only one man to reach a trapped patient and rescue him. After the initial rescue, 2 men may be able to undertake further movement through a narrow space. Ensure that the tied wrists do not interfere with any breathing apparatus the rescuer may be wearing. The Neil Robertson Stretcher. It is a simple device for moving an injured party safely from a difficult place where the ordinary stretcher would be useless. The injured party is enveloped in a protecting but somewhat flexible case, so that he takes up as little room as possible. The stretcher can be bent slightly in turning sharp corners in narrow passages, as when being hoisted up the ladderways from engine rooms or through the hatches of cargo tanks. The stretcher is made of stout canvas, stiffened by wooden slats. The portion A takes the head and neck, which are steadied by a canvas strap passing over the forehead. Thus, the head of an unconscious patient can be steadied. The portion B is wrapped around the chest, notches being cut on which the armpits rest. This part has 3 canvas straps, which are used for fastening the stretcher round the chest. The portion C folds round the hips and legs down to the ankles. It is secured by 2 canvas straps. A central backbone of stout rope passes along the undersurface. This has 2 beckets passing out from it on either side, which can be used as handles for carrying the patient or for securing tackles when he is slung horizontally. At the head end, the rope ends in a grommet, which takes extra purchase from 2 brass eyelets let into the canvas. At the foot end of the rope is a galvanized iron ring, which is secured to the stretcher by a span going to brass eyelets in the canvas. The patient should be lifted onto and secured in the stretcher with caution, getting ready to lift the injured party sufficiently for the Neil Robertson stretcher to be slid under him. With only 3 attendants, the wrists of an unconscious patient have to be tied together, but not tightly. Lower the patient slowly. If he is unconscious, support his head. Ensure the patient's armpits are in the correct place before you finish lowering him. Strapped up, the arms can be strapped inside or outside the chest section of the stretcher, depending on the injuries. Carrying the patient. The patient should be carried by 4 men, if possible. Keep the head section level with the chest section if the neck may be hurt. Hoisting an injured party through a hatch. When passing the injured party through a narrow hatch, or lifting him up over a height, or lowering him to a boat alongside, put the lifting hook or a rope through the grommet at the head end, and a further steadying rope through the galvanized ring at the front end. Moving an injured party vertically. To steady the stretcher, a rope goes from the foot of the stretcher to a seafarer below. Congratulations! You have successfully completed Part 10. Bandaging, enclosed spaces, infectious diseases, personal health and hygiene. Please click the Next button to proceed. Bandaging. Bandages are required to apply and maintain pressure on a wound to stop bleeding, to keep a dressing in place, to provide support, and to prevent movement. Note: never use cotton wool as the first layer of a dressing. When using lint, always put the smooth surface next to the skin. Covering a break in the skin helps to control bleeding and protect against infection. Dressings are pads of gauze or cloth that can be placed directly against the wound to absorb blood and other fluids. Cloth bandages cover dressings and hold them in place. Step 1. Dress the wound. Put on gloves or use other protection to prevent contact with the victim's blood. Clean the wound with mild soap and water. Apply a small layer of topical antibiotic if desired. Place a clean dressing over the entire wound. Gauze dressings let in air for faster healing. Non-stick dressings have a special surface that won't cling to the wound. If blood soaks through the dressing, place another dressing over the first one. Step 2. Cover the bandage. Wrap roller gauze or cloth strips over the dressing and around the wound several times. Extend the bandage at least an inch beyond both sides of the dressing. Don't wrap the bandage so tight that it interferes with blood flow to healthy tissue. Step 3. Secure the bandage. Tie or tape the bandage in place. Don't secure the bandage so tight that fingers or toes become pale or blue. Step 4. Check circulation. Check circulation in the area below the bandage after several minutes, and again after several hours. If circulation is poor, the skin may look pale or blue or feel cold. Signs of poor circulation also include numbness and tingling. If circulation is reduced, loosen the bandage right away. If symptoms continue, get medical care. Enclosed spaces. An enclosed space is one that has limited openings for entry and exit, has inadequate ventilation, and is not designed for continuous worker occupation. The atmosphere of any enclosed or confined space may be deficient in oxygen or contain flammable or toxic fumes. These conditions may put at risk the life or health of the persons entering it. Oxygen deficiency can result in anoxia. Anoxia happens when your body or brain completely loses its oxygen supply. Anoxia can be especially harmful to your brain. After about 4 to 5 minutes without oxygen, your brain can become permanently damaged. Without oxygen, your brain cells can die, and many of the functions that your brain controls can be affected. The longer your brain goes without enough oxygen, the more likely you may experience long-term complications, including death. The symptoms commence with giddiness, breathlessness, and unconsciousness, and progress onto brain damage causing memory loss, mental instability, paralysis, coma, or death. The following precautions are to be followed prior to entry into enclosed spaces. An enclosed space entry permit system must be strictly followed. The space is to be thoroughly ventilated and confirmed by testing of the atmosphere. There must be sufficient oxygen to support life, 21%, insufficient flammable gas for the purpose, and toxic gas must be less than the TLV. Proper protective equipment, overalls, hard hat, safety shoes, etc., and approved torchlights, non-sparking tools, etc. must be used. Vigilance and alertness must be exercised. The atmosphere must be monitored and all precautions observed while the job is underway. Personnel must be cautioned against overconfidence or negligence. Protective clothing and the workplace is to be cleaned up after the job is done and things left neat and tidy. Infectious diseases. Infectious diseases are disorders caused by organisms, such as bacteria, viruses, fungi, or parasites. Many organisms live in and on our bodies. Under certain conditions, some organisms may cause disease. Some infectious diseases can be passed from person to person. Signs and symptoms vary depending on the organism causing the infection, but often include fever and fatigue. Each infectious disease has its own specific signs and symptoms. General signs and symptoms common to a number of infectious diseases include fever, diarrhea, fatigue, muscle aches, coughing. Follow these tips to decrease the risk of infection. Wash your hands. This is especially important before and after preparing food, before eating and after using the toilet. And try not to touch your eyes, nose, or mouth with your hands, as it's a common way germs enter the body. Get vaccinated. Vaccination can drastically reduce your chances of contracting many diseases. Make sure to keep up to date on your recommended vaccinations, as well as your children's. Stay home when ill. Don't go to work if you are vomiting, have diarrhea, or have a fever. Don't send your child to school if he or she has these signs either. Prepare food safely. Keep counters and other kitchen surfaces clean when preparing meals. Cook foods to the proper temperature using a food thermometer to check for doneness. Also, promptly refrigerate leftovers. Don't let cooked foods remain at room temperature for long periods of time. Practice safe sex. Always use condoms if you or your partner has a history of sexually transmitted infections or high-risk behavior. Don't share personal items. Use your own toothbrush, comb, and razor. Avoid sharing drinking glasses or dining utensils. Travel wisely. If you're traveling out of the country, talk to your doctor about any special vaccinations, such as yellow fever, cholera, hepatitis A or B, or typhoid fever you may need. Health and hygiene on board. It is the responsibility of individuals to ensure high standards of personal hygiene and to look after their own health. It is the moral responsibility of all on board to observe hygiene and promote good health. Attention should be paid to personal cleanliness, sensible diet, adequate sleep during rest periods, regular exercise, avoidance of excess alcohol or tobacco, prompt attention to cuts or abrasions, maintenance of working clothes and protective equipment in a clean condition, appropriate dress for the working climate, and avoidance of recreational drugs. Congratulations! You have successfully completed Part 10.